Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we're going to have Lindsey Clemmons presenting first. She's currently a PGY1 pharmacy resident at OhioHealth Grant Medical Center, and today she is presenting a journal club on Ticagrelor and aspirin, or aspirin alone after coronary surgery for acute coronary syndrome.
Thanks for having me. Thanks for the introduction. We're going to talk a little bit about the TACSI trial, or Ticagrelor and aspirin, or aspirin alone after coronary surgery for acute coronary syndrome. And this kind of drew my interest, especially because we have a couple new cardiothoracic surgeons here at Grant that have started, and we're starting to do more open heart procedures, more cabbages, and I felt like this was a trial that we could probably apply to some of our patient population. So hopefully by the end of this journal club, we will be able to evaluate the safety and efficacy of dual antiplatelet therapy, specifically Ticagrelor and aspirin versus aspirin alone in patients who received a cabbage. And then we'll also apply the results of this trial to post-cabbage patients and their antiplatelet therapy decisions. So to start off with the background and methods, as we know, ischemic heart disease and acute coronary syndrome is very prevalent within the United States, especially. And ischemic heart disease affects nearly 20.5 million people within the United States. Statistically, there's about 650,000 revascularization procedures performed annually in the United States, and that breaks down to about 450,000 PCIs or 200,000 cabbages. So a cabbage specifically, as you can kind of see in the picture, it's a surgical procedure that bypasses a blocked or critically narrowed artery that's often caused by cardiovascular disease in the heart. This graft, the new artery, can help improve blood flow to the heart muscles, relieve angina symptoms, and then reduce risk of another heart attack. And then they typically use a healthy blood vessel from the arm, leg, or chest to kind of create a detour or bypass around the blocked artery of the heart to restore blood flow. Now, a PCI tends to be less invasive, so we tend to use that procedure more often. However, there are some indications where a cabbage may be more preferred for the patient. In this case, it would be a patient with complex anatomy, or they have a heavy atherosclerotic burden, where just a PCI would not cut it in terms of reestablishing blood flow. Additionally, the national cabbage in-hospital mortality rate is about 2%, showing that this is not an entirely safe procedure, but we have developed methods to make it as safe as we can for patients. Specifically, this trial was looking at DAPT, so dual antiplatelet therapy, which is a combination of aspirin and a P2Y12 inhibitor, typically clopidogrel, prasugrel, or ticagrelor. And as we know, P2Y12 inhibitors are antiplatelet agents that block ADP from binding to the P2Y12 receptor on platelets. And this reduces platelet activation and prevents platelet aggregation. And why this is so important in ACS especially is that thrombus formation in ACS is mostly driven by platelet aggregation. The use of DAPT in these patients has been shown to reduce major recurrent ischemic events. And through other trials that have been conducted over the years, Ticagrelor and prasugrel are commonly preferred over clopidogrel just due to the decreased risk of major bleeding with Ticagrelor and prasugrel compared to clopidogrel. And also they tend to have better graft patency. Specifically after a cabbage, ACC AHA guidelines recommend that patients should receive 12 months of DAPT. And this is a class 1 recommendation. And this has been shown to improve graft patency, but can increase the risk of postoperative bleeding. Despite it being a class 1 recommendation that patients receive 12 months of DAPT, overall adherence to the guidelines kind of remains low, which is why the investigators in this trial kind of came up with the idea to investigate DAPT versus aspirin alone. And why the adherence remains low is mostly because the recommendations rely on extrapolation from patients who did not receive a CABG. So this has not specifically been studied in patients with a CABG. Overall, the evidence for the use of DAPT in post-CABG patients is minimal. So anything we can do to hopefully decrease the risk of bleeding and increase graft patency is going to be beneficial to the patient. So they embarked on this study to investigate if 1 year of DAPT, specifically with ticagrelor and aspirin compared to aspirin alone, would reduce the risk of a composite outcome among patients with ACS that underwent a CABG. The composite outcome was death from any cause, a new myocardial infarction or stroke, or any new revascularization that needed to be done. Once they came up with this purpose, the investigators designed an open label trial where the patients were randomized 1-to-1 in 5 different Nordic countries. The patients that were included were those that are 18 years or older and those that had an acute coronary syndrome within 6 weeks prior to the primary CABG. They also needed to perform written informed consent. Exclusion criteria, of course, any contraindication to trial drugs, if they were on any oral anticoagulation, because we don't necessarily want them on triple therapy, and then anyone with any sort of organ dysfunction, so CKD patients warranting dialysis, liver disease, or a bleeding disorder. The groups were then split into either receiving DAPT with ticagrelor 90 milligrams twice a day and aspirin 75 to 100 milligrams once a day, or just aspirin 75 to 160 milligrams once daily. And it's important to note that patients that maybe were on clopidogrel or prasugrel beforehand did not have a washout period or receive a higher loading dose of the ticagrelor when switching. As far as outcomes go, the primary efficacy outcome that they were mostly looking at was that composite outcome, so death, MI, stroke, or repeat revascularization within 1 year. Their primary safety outcome was the first occurrence of major bleeding, and major bleeding here was defined as any bleeding that warranted hospitalization. For secondary outcomes, they looked at the composite primary outcome event, so the breakdown of what caused the composite event or major bleeding, and then they also looked at severe dyspnea or new onset renal failure, as these can be some side effects of possibly using ticagrelor. And renal failure was defined as anything that could include acute kidney failure, chronic kidney disease, or unspecified kidney failure. To determine a significant difference, the investigators used an 8% event rate of major adverse cardiovascular events at 1 year in the aspirin monotherapy patients. And they derived this value from a previous trial called the Plato trial that compared ticagrelor and aspirin with just clopidogrel. And the primary outcome occurred less frequently in the dual antiplatelet group and occurred about 13% in the clopidogrel group. Using this, and then also an analysis of a registry that is present in Sweden that provides continuous information on secondary prevention and cardiac rehabilitation performances, they evaluated the all-cause mortality in post-CABG patients after discharge at 1 year, and the all-cause mortality was higher in the aspirin alone group. So this is how they came up with the 8% event rate to develop to show a statistically significant difference. From that, they developed a power where they needed 1,056 patients in each arm, and then ended up expanding the trial to include 2,200 patients total, hopefully. As far as results go, they screened almost 7,000 patients and excluded about 4,700. The groups were pretty evenly split with about 1,100 patients in each group. So they did meet their power and sample size with a total of 2,201 patients in the intention to treat group. The demographics here are pretty similar between the two groups. What was most notable to me in particular is the similarity in the mean Euroscore 2 score. This is a score used in Europe that predicts the risk of in-hospital mortality after a major cardiac surgery. So I thought that was pretty good that they had very similar numbers in that regard. And then also their indication for surgery was comparable as well. For the primary outcome, as you can see here, the groups both had pretty similar numbers of patients that experienced the primary outcome. So again, the death from any cause, MI or stroke or revascularization with a p-value of 0.77, which indicates no statistically significant difference between aspirin alone and ticagrelor and aspirin in preventing any part of the composite outcome. So it's pretty notable that you could use either and hopefully improve a patient's outcome. As far as secondary outcomes go, they wanted to look at a breakdown of the composite outcome. So the 4 individual characteristics we mentioned, and across the board, they were pretty comparable. So similar amounts of revascularization, MI, stroke that were experienced by the patients as well. The most important part that I kind of drew from the secondary outcomes was the major bleeding event. So as you can see here, there were 54 patients in the DAPT group that experienced a major bleeding event and only about 22 patients in the aspirin alone group. So this yielded a hazard ratio of 2.5, which indicates a 2.5-fold increase in risk of major bleeding event with ticagrelor and aspirin, which I think is pretty notable in this case specifically. Additionally, with the side effects that we are nervous about or want to watch with ticagrelor, it was evident that more patients in the ticagrelor group suffered from severe dyspnea, almost 3-fold more. And actually, there was a lot of discontinuation and non-adherence to the ticagrelor because of this side effect. Additionally, more people in the new onset renal failure group exhibited that than in the aspirin alone group as well. So in conclusion, the study demonstrated that 1 year of treatment with dual antiplatelet therapy specific to ticagrelor and aspirin did not result in a lower incidence of death, MI, stroke, or repeat vascularization than aspirin among post-CABG patients. And though it wasn't analyzed formally, you can see from the analysis that they did do, this provides some evidence of increased risk of major bleeding with the dual antiplatelet group compared to aspirin alone. So what I evaluated from this study in terms of limitations and strength, the authors themselves noted that they did not assess graft patency over that 1 year period of time. However, they will evaluate this in an ongoing extension of the trial. So they were able to sort of address that limitation. There's also the non-adherence to ticagrelor could also have been a limitation with less people fully completing the year's worth of dual antiplatelet therapy. Additionally, less severe bleeding events may have been underestimated just because the definition of major bleeding tends to differ amongst groups of people. And then to me, there were maybe possible external validity concerns within the United States as some of their heart failure, diabetes, other demographic characteristics seemed a bit lower to what, from my experience, of what patients would present with here in the United States. The strengths of the study, they did have a very large patient cohort, so they met power and were able to detect that no statistical significance. They are going to follow the patients for up to 10 years after the conclusion to monitor for more of these outcomes as well. And then it does address an evidence gap in dual antiplatelet use post-CABG, since that initial recommendation is kind of extrapolated in CABG patients specifically. So my overall impression is that I felt like this was a pretty strong study. It evaluated a gap in literature. However, the greater diversity in patients in the United States may limit the external validity. I was starting to think about maybe other P2Y12 inhibitors that we use in practice. And to me, I feel like we would see similar results with a prasugrel-based DAPT in terms of bleeding, since prasugrel and ticagrelor have been shown to have significantly higher major bleeding risks compared to clopidogrel and have similar bleeding risks to each other. I would expect to see a greater incidence of the primary outcome of the death, stroke, revascularization in clopidogrel-based DAPT as as prasugrel and ticagrelor have been preferred over clopidogrel for ACS patients undergoing a PCI due to superior efficacy. And my takeaway on if I would apply this to some of my patients is I feel like this study was impactful and it may impact my current practice, but kind of more on a patient-to-patient basis, just evaluating the risks and benefits and looking at any acute coronary syndrome events that they have had in the past. My references, and I'm looking forward to any questions you may have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.